So, dear students, we at the Department of Anesthesiology and Perioperative and Critical Care Medicine endeavor to deliver all the teaching in a comprehensive and integrated manner. We not only focus on providing you knowledge and take care of the cognitive domain, but we also wish to train you in the other affective skills and psychomotor skills. Today I will talk to you regarding paravertebral block. You must have received the pre-learning material which I had sent to you, and I am going to ask you a few questions. How many of you have read this pre-learning material? Yes, good. Now I'll ask you a few questions. One, the average volume which is required for a unit block of the paravertebral space is 3 to 5 ml, whether it is true or false. The paravertebral block is given in thoracic region. This is true or false? You? Good. So, after today's talk, you will be able to know and understand what is paravertebral block, when this paravertebral block is required and is helpful, what is the basis, the anatomical basis on which we can give a block successfully, why we wish to use paravertebral block as one of the modalities for providing analgesia to the chest wall following thoracic surgery or rib fractures or in the upper abdominal surgery. I will also acquaint you about various techniques used for paravertebral block, and I will brief you about what all complications one can have if not taken care of properly. Now, as the name suggests, paravertebral, you know that in the midline there is vertebral column and there are several structures situated adjacent to it. So, when we talk about block, it means blockade of neural pathways. These neural pathways are in the form of nerve trunks, individual nerves, nerve trunks and plexuses. Some of them are located adjacent to the vertebrae. So, in cervical region we have cervical nerves, deep cervical block, which is a somatic block, and we have stellate ganglion block, which is a sympathetic block. Similarly, in lumbar region we can have lumbar plexus block, which is a somatic block, and celiac plexus block, and lumbar sympathetic block is the sympathetic block. All these blocks are technically paravertebral block, but in thoracic region the paravertebral space is very well defined. I will let you know in the coming slides. It is very well defined, and unless specified, when you are mentioned about paravertebral block, it means thoracic paravertebral block. It is given unilaterally and it is meant to block the emerging nerves. So, this is a wedge shaped space, and as the dorsal and ventral, these are the dorsal rami, ventral rami, they emerge out of it, they can be blocked in this area which is called paravertebral space. You can give it on one side if the requirement is for one side. For example, you have done a cholecystectomy which is on the right side, so you would require only the right sided paravertebral block. However, when the surgery or the problem or the pain is on both sides, you need to give paravertebral block on both sides if you prefer to use this as the technique and the modality for anesthesia or analgesia. Now, when all this can be useful, It is very useful following breast surgery because it single injection, if higher dose is given or a large dose is given, it can block even 5 segments, which may be enough for the breast surgery. Some anesthesia providers use paravertebral block as the sole modality for providing anesthesia for breast surgery. However, mostly it is given for post-operative pain relief or as an adjunct to general anesthesia. Another situation where it can be helpful and good is rib fractures. So, multiple rib fractures you can give paravertebral block. Similarly, following cholecystectomy or upper abdominal surgery, it is a very useful modality, and whenever epidural block is not indicated due to whatever is the reason, then paravertebral block may be one of the good modalities to maintain and preserve the post-operative pulmonary function. Now, what is paravertebral block? As I had mentioned to you, it is a wedge-shaped space, right, anterolateral to the body of the vertebra. This is the thoracic vertebra. Its medial wall is formed by the intervertebral foramina, the vertebral body, the intervertebral foramina, and the disc, right, and the posterior border is formed by the superior costotransverse ligament. The part of the lamina and transverse process also aid in the formation of its posterior wall. Anteriorly, the pleura is there. So, this is the anterior, this is the parietal pleura. The visceral pleura of lung is almost attached to the lung. So, what you appreciate is pleura only, and above this its apex communicates laterally with the adjacent intercostal spaces. So, this has got a important implication. Whereas it is a space, so it is expected that the volume deposited in a paravertebral space at a particular level will be deposited there, and when more volume is given, it can ascend upwards and downwards. So, it can ascend cranially as well as caudate. But with this kind of a communication, there is a possibility of lateral spread, and through the intervertebral foramina there is a possibility of excess of the local anesthetic in the neuraxis, and that can result into a more extensive block, and when a large volume is given, it can result into an epidural block. And there are reports that when given on one side, the effect has also been encountered on the other side. That is how you can explain it, that you have given on one side, why and how the effect has been discernible on the other side. Now, what lies inside the paravertebral space? Obviously, the emerging nerves from the particular segment of the spinal cord, the ventral and the dorsal nerves, the white and grey rami communicantis to the sympathetic chain, and intercostal vessels and fat. So, this is the paravertebral space, and you see that intervertebral space is there, retro laminar space is there, and this is the erector spinae compartment. So, this is outside this. When we will talk about the technique, you will know that this muscle comes on the way. Now, why do you prefer paravertebral block over other techniques, but particularly the epidural block? One, though it is considered an advanced block, it is possible to learn it systematically and perfect it quite nicely. As is possible with other techniques, the neurological complications risk is much less, the hypotension is less, there is no urinary retention, less sedation, and overall it is a very useful technique. Now, how to give paravertebral block? So, there are two basic standard techniques. One is the landmark technique, which has been practiced for long years, for several decades, and other one is a recent innovation, and that is the USG guided technique. For that, one has to be familiar with the ultrasound images and scanning. Now, what are the drugs required for giving the block? The local anesthetic, obviously. The drug has to be of sufficient concentration which can block somatic nerves. So, when we talk about bupivacaine or its levodextromer, it is 0.5%. If it is lignocaine, which is a shorter acting drug, it has to be 2%. This is the equivalent concentration for ropivacaine. So, you require a somatic nerve blocking concentration. The volume required for one segment is around 3 to 5 milliliter, and if you want to block 4 to 5 milliliter segments in a single injection, you have to deposit a large volume, and it is possible for this volume to spread upwards, downwards, and some of it laterally also. It can also spread in the prevertebral plane and into the epidural intercostal space or both sides, and it can result into an epidural block or can extend on the other side. So, contralateral paravertebral block. Now, for the landmark technique, you have to be familiar with the anatomy and the landmarks. These techniques are blind techniques, and they are the conventional method of giving the block. So, for landmark technique, you need to know certain landmarks. This is given adjacent to or parallel to the midline, and therefore, you call it paravertebral block. So, in order to give a block, you need to know what area you are blocking, what is the dermatomal supply of that area, and what is the corresponding spinal level. In order to know the spinal level, you have to feel and count the spines. One of the commonly used posture for giving the block is in sitting position. This one is a patient in lying position. This position is usually used for patients who are already anesthetized. But when we give a block before anesthesia or in areas where anesthesia is not being given, mostly sitting position. So, one of the landmark here is the spinous process of the 7th cervical vertebra, which is most prominent. Another landmark is T7, 7th thoracic spine, and that is at the level of angle of the scapula, right. So, you can start counting from here 1, 2 downwards, and once you are sure about it, you have to mark it with the indelible ink, and then you have to measure a distance of around 2.5 centimeters away from the midline and make a mark and make a grid like that. So, you can identify, these are the pictures which are explaining that this is the midline, this is the area you have identified, the distance measured is 2.5 centimeters, you have to use a scale, and thereafter that becomes the point of entry of the needle, right. Now, how much to go inside? This distance has been suggested for adults on the basis of cadaveric studies, and we have found that up to this distance, mostly when we go downwards at right angles in a tangential coronal plane, then we are likely to hit the transverse process or the lamina. So, a guard at 4 centimeters is provided so that you do not go far beyond and do not cause injury to the pleura, which is a very structure very close to it. So, that has to be avoided at all intervals. The volume given is around 5 milliliters, as I had mentioned, and if you use a neuromuscular monitor as is being done here, then you can be more sure, and it is a partially assisted technique. Okay. Now, this is a picture where you can see that what all structures you will be crossing. So, you will be crossing the skin, subcutaneous tissue, and then muscles, and through the interspinous space you are trying to go there, which is the target area. Now, this is the transverse section at a level, it is a thoracic level. Now, look at this diagram carefully and tell me what is the level of this diagram. Can anyone tell me? Look at this area very carefully, right? And look at the muscles which you are getting. You know that the muscles of the back in upper thoracic region, the first muscle you encounter is the trapezius, and up to T5 you have the next muscle as the rhomboids, and after that erector spinae muscle. Okay. So, you can differentiate. Now, when you are going to use the ultrasound guided technique, you have to identify the structures. Now, with the advent of ultrasound, we no more give blocks as the blind blocks. The ultrasound helps and assists you for accurate and real time administration of the block. It is something like a stick of a blind person. So, either you are having a good idea about what all is there around you, there is a sense of perception of the depth and other things, and on the basis of the anatomy you can go for a successful walk. So, when you go for an ultrasound assisted technique, the areas of interest have to be the back muscles. You have to identify the 3 muscles which I have mentioned in succession: trapezius, rhomboids, and erector spinae. You have to identify the ribs and the transverse processes. So, you start scanning from lateral to medial. The key point here is that when you see the ribs, they are hypoechoic and rounded, whereas the transverse processes are flatter, are sine wave sort of square wave pattern is there. Then you need to identify the costotransverse ligament through which you will be injecting, and finally the pleura. The hallmark of pleura is that it is a shining white structure, and in a spontaneously breathing patient you can see the pleura moving. For this block, it is ideal and best to select a high frequency probe because the depth at which you are going is not too much. An 18 gauge Tuhi needle may be used, and a 10 ml syringe may be used for injection with the Vinnie's immobilization technique using a injection extension tubing, and depending on if you are going for single one, 15 to 20 ml drug is required. Now, there are 2 approaches for this. One is the US guided approach, where you just want to use the ultrasound to confirm the anatomical landmarks, and thereafter once you confirm the landmarks, you go for the block as the landmark technique. But what is mostly preferred is the ultrasound guided approach, wherein the transducer is put on the back in a paramedian plate, either longitudinal or transverse orientation, keeping away from the midline and trying to know and identify the rib and intercostal spaces, and then moving medially, gradually moving medially. Okay. Now, this is one picture which gives you that this is a patient lying, and this is transverse orientation of probe. Now, in transverse orientation, some of the practitioners use this approach. Here you have to make sure that you are able to visualize the tip of the needle all the time. That appears like a bright star when it is in front of the ultrasound. As I mentioned, when you are laterally, the ribs are seen and they are in round shape and they are smaller, and when you move on the other side medially, then the transverse processes can be seen which are flatter. Now, what all areas are of interest here? This is how pleura is seen. This is a static picture, so you cannot see the dynamically moving pleura. But what is important is to identify the pleura, the transverse process, the paravertebral space and superior costotransverse ligament. This is placement, transverse placement at the level of transverse process, lamina, coming closer here, and at the level of ribs, this is how you see the image. This is the lamina, shining lamina, this is rib, and when you come at the level of transverse process, this is how you see the wedge shaped transverse paravertebral space is there, right, and this is the shining pleura, and this is the intercostal membrane continuing with the superior costotransverse ligament. This is another picture a little lower down. Then you can have a longitudinal orientation of the transducer. So, earlier one was the transverse, and here you are having longitudinal. So, in longitudinal you see that at the target area, this is the transverse process, this is the rib, and this is the pleura, and this is the intercostotransverse membrane or the costotransverse ligament, and your deposit has to be here. Your incoming needle will be like this. This is the point of injection. Same picture a little, but this one is in transverse plane. Now, what all can happen? One of the most dreaded problem which can occur is you can puncture the pleura if you are not very careful, right? So, you need to identify the pleura and identify the moving pleura. This can be done easily in a ultrasound guided approach, whereas in landmark approach you have to take caution that you don't go too much deep, you don't go more than 4 centimeter deep. So, this can happen. If this happens, this can result in tension pneumothorax. Besides that, if you don't use adequate concentration or adequate volume, or if you don't take a point of entry which is appropriate, then you can have an effect which is a little less than desirable. As I had mentioned to you that there is communication through the intervertebral foramina, and if you use a large volume, it can result into epidural spread, and it can also spread contralaterally to the other side. Since the sympathetic plexus is close and in the same plane in cervical region, it can block the sympathetic ganglion present there, that is, it can cause block of the stellate ganglion, and that will result into Horner's syndrome, characterized by, who will tell me what are the features of Horner's syndrome? Sympathetic paralysis, meiosis, anhidrosis, right, and increase in body temperature because of vasodilatation on the same side. In a rare situation, particularly if you are going more medially, or if your tip of the needle is going medially, it can result in a spinal anesthesia. So, whenever we identify and enter the paravertebral space, we need to aspirate. We need to make sure that we are not aspirating clear fluid which may be CSF. It could be cerebrospinal fluid, and if you inject at this level, it is going to result in spinal anesthesia, and if you inject a large volume, it can result in total spinal anesthesia. The other thing which can happen is you may inject intraneurally, you may inject intravascular. So, the dictum is that you always aspirate first, make sure that the blood is not coming back, and these are the standard precautions for when you give a block. Now, this is a short video which will you will all recall everything in a 3 minutes video. So, what all I have taught you in preceding 20 minutes, you will be able to see it. Can you raise the sound, please? Can you raise the sound, please? Okay. So, here the person is trying to tell you that these are the spinous processes and these are the emerging nerves from the intervertebral foramina.
For paravertebral blocks to be effective for surgery or powerful analgesia, you usually want to do one block at the level of incision or the point where you have the most pain, rib fractures and things like this. And then you want to do 2 levels above that and 2 levels below the incision. Ultrasound guided paravertebral blocks can be very challenging, particularly in patients who do not image well. In this patient who images very well, we chose to do ultrasound guided out-of-plane techniques, and it's probably one of the safest methods to do paravertebral blocks. Let's watch the video, which will be T6. There we go, it's a nice image. Transverse process, we can see the paravertebral space. That would be rib, parietal pleura. If I tilt
this wedge-shaped space is a paravertebral space.
There we go, injection of more cholesterol.
Clear?
Okay.
This is the pleura.
The needle for the block. There you go. We want to pass. Try to trust this process, measure. Never trust the ultrasound, always want to measure upon your needle. So it's 4 centimeters, 3.5. There you go. Aspiration negative. Injection results in a pushing of the parietal.
Now, this is a confirmation that you have done it at the correct plane. So, when you inject, the space is distended, the pleura is pushed down.
This is the best way to do it. And finally,
Clear?
do one more level.
You have seen real time spread of the drug.
This will be adequate. So
This is possible only in the ultrasound guided approaches.
be a bit better. That is a transverse process, and that's pleura. Okay, so let's do this. More kinesthetic. This helps us find the path of the needle. And now the block needle goes in. Now once we know where to place it, there you go. Down to 3.5 centimeters, aspiration negative. And that was the ultrasound-guided paravertebral blocks at the thoracic level using out-of-plane approach. For complete video and to access an amazing compilation of no.
Now this was all about how to go for a thoracic paravertebral block. So all the theoretical knowledge and related information I have conveyed to you. If any of you has any problem, you can come to me and ask questions right here. After this, as a follow-up, I am going to demonstrate to you the uses of nerve stimulator guided technique of paravertebral block and ultrasound guided technique for paravertebral block in volunteers. I will allow you to do screening and scanning of these patients, and I will ask you to identify the areas of interest and what is the point of deposition. Finally, the hands-on training, at the end of the hands-on training, you will be able to observe procedures done by expert anesthesia providers, and ultimately the goal is to teach you and permit you giving blocks under supervision. So that's all for today. Thank you very much.